capsule so that it remains stable. And also while hydrating the side port, you should make sure that the fluid weight doesn't propagate under the lens and lift it up, because then there will be change of position. Then here, Virion image guided system was used for alignment of the toric IOL. So Virion, it captures the images of the eye and notes down the details of the scleral limbal vessels and the iris detail. And then it calculates IOL power, and also it makes a surgical plan and creates an overlay which will be projected onto the cornea during surgery. And then after cortex removal, so you have to fill the chamber with OVD, and then you can see here the axis of alignment is 104. So finally it gives that line 104. So you have to align the 3 dots along the line. So here the only one advantage is that you don't have to consider about the fading of the dye or the smudging of the dye spread and all, but it's a machine dependent thing. So machine, you can't depend on 100% always. And sometimes we'll have to customize the IOL. In this patient, so had a keratometry reading of 46.28 at 180 and 55.7 at 30, and astigmatism was plus 9.5 at 38 degrees. And the topography showed features of keratoconus, but since the astigmatism was regular, went ahead with implanting toric IOL. This was a custom-made lens, plate haptic lens, that was customized by the care group, and it has a hole there on the haptic that has to be positioned to the left side while loading the IOL and while injecting it. So this is a slightly heavy lens, it's a plate haptic lens, and that has to be injected very carefully. And then there is no need of axis marking because it is intended to be placed in the horizontal axis. So finally you have to align with the reference marks there. And then finally the patient had a visual acuity of 6.9 with plus 0.75 cylinder at 100 degree. So to conclude, right patient selection and a good preoperative assessment and a meticulous surgery generally ensures good result, but never promise the patient that we are going to give zero astigmatism. Thank you.
Thank you, Dr. Sandhya. I think that was a very beautiful presentation with the lovely videos. One point regarding that customized IOL. I think if we are ordering the customized IOL, toric IOL, we need to counsel the patient that it would take some time, right?
It will take some. Usually they give in 3 weeks to less than 1 month time.
Around 1 month.
Around 1 month time.
So that is one thing. If you're going for a customization, we need to tell the patient that they'll have to wait. Yeah, wait for 3 weeks. Yeah. Okay. Thank you. So next I invite our next speaker, Dr. Manju. So Dr. Manju is currently working as a glaucoma consultant at Giridhar Eye Hospital, Kochi. And she'll be talking on the topic coexisting cataract and glaucoma, whether we have to go for combined or a sequential surgery.
Thank you, Dr. Ambika, for the invite. I'll be talking on the management of coexisting cataract and glaucoma. Glaucoma and cataract often coexist. So the choices include, one is sequential approach, that is you can do a glaucoma filtering surgery first followed by cataract surgery whenever indicated. Or you can do a cataract surgery followed by a glaucoma surgery later. Or you can do a combined surgery and do both the surgeries in one sitting. So what are the things you have to consider before deciding? You have to find out the extent of glaucomatous damage, the stage of the disease, and the presenting intraocular pressure, and what is your target IOP. And do a perimetry to see the extent of the severity of the damage, and consider the number of AGMs the patient is currently on and how the patient is responding to the medication, and make sure the patient is compliant and tolerable with the anti-glaucoma medication, and also the amount of cataract. Other factors which you have to consider include age of the patient, ocular and systemic comorbidities, whether the patient is able to undergo 2 surgeries at 2 different times, and socio-economic status, whether they are able to afford 2 different 2-stage procedure. So now let us look at the cataract surgery alone. It definitely gives a visual improvement, and it increases the anterior chamber depth and angle width more in angle closure disease, but to some extent in open angle glaucoma also. Intraocular pressure reduction is more in angle closure compared to open angle, and this IOP reduction is usually related to the pre-op intraocular pressure. A study from PGI has shown that the cataract surgery leads to significant drop in IOP across the spectrum of angle closure disease with visually significant cataract. So, cataract surgery alone may be considered initially for IOP control even in advanced or medically uncontrolled primary angle closure glaucoma, followed by glaucoma filtering surgery later if required. So what are the options of cataract surgery? You can do either a phaco or a small incision cataract surgery. So as you all know, phaco takes only a small area for the surgery and the superior conjunctiva is untouched, so the trabeculectomy future will be easy. But if you are doing an SICS and in the superior quadrant, future trabeculectomy will be difficult. And the complications post-op include the IOP spike will be there in the immediate post-op period, and this you have to manage in addition to the anti-glaucoma medications which the patient is already on, and the post-op CME may be slightly more in glaucomatous patients, and patient has to continue the anti-glaucoma medications which they are already on. Glaucoma filtering surgery alone, it helps to achieve a low target IOP compared to cataract surgery alone. So when you want to have a very low target, you may have to opt for a filtering surgery, and the better success rate compared to combined surgery if you do a filtering surgery first and then do a cataract surgery. So as you all know, but the problem with the filtering surgery is not the surgery per se, the identification and the management of post-op complications for the success of the bleb. And it doesn't give any visual improvement, rather it may cause a cataract formation or it accelerate the existing cataract. And patient may need a cataract surgery later, which in turn